Hi, I'm Dr. Greg Butchko from Banff Sport Medicine. Welcome to the patient information video for your anterior cruciate ligament or ACL reconstruction surgery. This video is designed to help you prepare for surgery and to know what to expect. We hope that it answers some of the questions and concerns you might have about your upcoming surgery at the Banff Mineral Springs Hospital. In this video, our team of orthopedic surgeons at the Banff Sport Medicine Clinic will explain what an ACL tear is and how it is diagnosed, explain the surgical procedure and outline the potential risks associated with surgery, as well as the possible consequences associated with not having surgery. We will also provide you with pre- and post-operative instructions, show you what the day of surgery will look like, and give you general guidelines for the post-op rehabilitation process. Let's begin with how an ACL tear is diagnosed. The anterior cruciate ligament, or ACL, is one of the main stabilizing structures found inside your knee. It functions to prevent your knee from giving out or buckling in rotational movements. ACL injuries occur most commonly in pivoting and contact sports. To summarize the anatomy of the knee, this is a diagrammatic representation of a right knee. The knee is made up of three main bones: the femur, or thigh bone, the patella, which is in front of the knee, and the tibia or shin bone. This is the anterior cruciate ligament, which connects the femur to the tibia. It is situated in front of the posterior cruciate ligament, or PCL. The function of the ACL is to prevent the tibia from shifting forward in relation to the femur, and also to control the rotation of the tibia in relation to the femur. There are two types of cartilage in the knee: the articular cartilage, which lines the ends of the bones, the femur, tibia, and the back side of the patella. And then there are the meniscal cartilages. This is the medial meniscus, the lateral meniscus, which are separate cartilage structures. They're crescent shaped, and they help the flat top of the tibia to conform to the round surface of the distal femur, and they also act as shock absorbers. They're important structures required to preserve the articular integrity of the knee, and we try to repair those if possible at the time of surgery. There are extra-articular structures such as the medial collateral ligament, or the MCL, which you cannot see arthroscopically. Also, the LCL, or lateral collateral ligament, is extra-articular. They are important for the side-to-side stability of the knee. There are other structures such as the posterolateral corner structures, which are not shown in this diagram, which are also important for stability of the knee. They may be injured at the time of ACL tear and may have to also be addressed surgically at the time of ACL reconstruction. The diagnosis of an ACL tear starts with listening carefully to the history of the injury given by the patient. It often includes a twisting or pivoting type motion associated with a pop or crack, followed by immediate pain and rapid swelling. Episodes or sensation of giving way may follow. The patient then undergoes a physical examination looking for looseness or laxity of the knee in the front to back and rotational directions. Finally, the patient may have further investigations including x-rays and possibly an MRI if the extent of the tear is unclear. It's important to emphasize that surgical treatment for your ACL tear is not mandatory. We know that with intensive rehabilitation and custom ACL derotation bracing, up to 1/3 of patients with ACL deficient knees are able to successfully return to unrestricted sports participation. Your other option is to consider a lifestyle change and avoid pivoting and contact sports. However, there are patients whose knees are so unstable that they give out with activities of daily living despite intensive rehabilitation and bracing, and surgical treatment is essentially the only option.
Hi, I'm Dr. Lori Heemster from Banff Sport Medicine, and I'm here to talk to you about your ACL surgery and the risks involved with having surgery and not having surgery. Now that you understand how an ACL tear is diagnosed and have chosen surgical reconstruction as your means of managing the injury, let's review the surgical procedure that reconstructs your ACL. A graft is used to reconstruct the torn ACL. The material used to make the new graft can come from either your hamstring tendons, your patellar tendon, or a donor tendon from a cadaver. Here we will describe ACL reconstruction using a hamstring tendon graft because that is the surgery we most commonly perform in Banff. Your surgery will begin with the surgeon making an incision approximately 2 to 4 centimeters long. This incision will allow your surgeon to harvest the graft to make your new ACL. Through the incision, your surgeon will take 2 of your hamstring tendons using a specialized instrument. The surgeon only strips off the tendons, not the muscle. The muscle will scar down to the muscle's position next to it, and there is some research that has shown that these tendons can partially regrow. Once the tendons are out of your body, they are sewn together and are now ready to be placed inside your knee. Before the graft is put in your knee, your surgeon will look inside your knee using a tiny camera to make sure there is no other damage. To do this, your surgeon will make 2 smaller keyhole incisions. An instrument called an arthroscope is placed through one of these incisions, and instruments to help feel the structures inside your knee are inserted in the second incision. Your surgeon will then repair or clean up any additional damage that is found. For example, if you have a meniscal tear, it will either be trimmed or, if possible, repaired. The surgeon will then prepare your knee for the graft. The first stage is cleaning out your damaged ACL. Next, the surgeon will drill tunnels through your shin or tibia bone and your thigh or femur bone. The graft is then pulled through these tunnels, replacing the missing ligament. The graft is then secured in place with a bioabsorbable screw and a metal button. Once the graft is fixed securely, the surgeon uses the arthroscope to make sure the new ligament is well positioned inside your knee. The arthroscope is then removed and your incisions are closed with stitches. The surgical areas are closed with dissolving stitches and covered with a sterile dressing of tiny strips. Gauze and a tensor bandage are then wrapped around your knee. There are some important things you should know about your surgery. With respect to the risks of the anesthetic, they are very rare, but can be discussed specifically with your anesthesiologist the day of your surgery. The risks associated with the ACL surgery itself include, but are not limited to, infection. This can include superficial skin infection as well as deep joint infection, deep vein thrombosis or DVT, and pulmonary embolus. If severe calf, ankle, and foot swelling occurs 3 days to 2 weeks after your surgery, a clot in a deep vein may have developed. Make sure you see a doctor as soon as possible. Skin numbness around the area where the incision was made, which usually improves with time but can be permanent. Large nerve or vessel injury, knee stiffness, persistent swelling, and possibly graft failure. The ACL does not heal well on its own. It is important to fix an injured ACL to prevent further episodes of instability or giving way, to prevent further damage to the knee, and in some cases to help prevent arthritis. Your surgeon will explain the different treatment options available to you. While this is considered to be an elective surgical procedure, there are risks associated with not having surgery. These include not being able to return to all activities, specifically those involving pivoting, twisting, or contact, an increased risk of meniscal or articular cartilage damage, persistent pain, swelling, and feelings of instability. Of course, ACL reconstruction is not for everyone, and it is important to understand that when you tear your ACL, there are a few treatment options available to you. These include lifestyle modifications, such as decreasing activity intensity or stopping your participation in pivoting and contact sports, as well as the use of a custom-fitted derotational knee brace. Now that we've discussed what is involved with the surgery itself, let's review what happens next.
Hi, I'm Dr. Mark Hurd from Banff Sport Medicine. This video will take you through your preoperative course and your postoperative program following anterior cruciate ligament reconstruction. The night before surgery, do not have anything to eat or drink after midnight. If you have important medications that you need to take each day, your doctor will tell you when to take them. Do not shave or prepare your leg in any way. If you have insurance forms, please bring them to the office either the day of or before your surgery. Your surgeon's assistant will make sure these forms are completely filled out and copied for your records. Insurance forms are not covered by Alberta Healthcare, and a fee will be charged for their completion. We recommend that you purchase or borrow a cold therapy unit and bring it with you to the hospital. These units help with post-operative pain and swelling management. You can purchase one of these units through our office or from a medical supply store. You should check with your extended health insurance, as the cost is often covered by these plans. Also, if you already have crutches, you should bring these with you to the hospital on your day of surgery so that you don't have to purchase them. The morning of surgery, you will come to the Banff Mineral Springs Hospital. You will check in at the front desk, and then you will be taken to the acute care area where you will meet a nurse who will take you to your hospital room. Here in your room, you will be prepared for surgery by the nurses, and you will also meet the anesthesiologist. You will be taken to the operating room area and finally into the operating theater. You will ask to be arrived early the day of surgery and may have to wait a while before your operation. You may want to bring something to read or do while you pass the time. Depending on what the surgeon found inside your knee and the repair that was performed, you may or may not be placed in a post-operative knee brace. Your surgeon will explain the findings of the surgery to you on the day of surgery. Due to our location and bed availability, most patients stay over one night. The morning after your surgery, the nurse may change your dressing, and the physiotherapist will teach you your initial rehabilitation exercises and crutch walking. You will go home on crutches, but you are allowed to bend your knee and put weight on your leg as tolerated, unless you are otherwise instructed by your surgeon. You need your crutches until you can walk without a limp. This usually takes 2 to 4 weeks. When you go home, it's actually normal to have some pain and discomfort. You should take the first week after surgery to rest. You will likely need some pain medication for about 7 to 10 days. Prescriptions for pain medication will be given to you prior to leaving the hospital. There are some things that you need to remember. For the first 2 weeks, use ice packs or the cold therapy unit to reduce pain and swelling. Make sure that you use a towel under your ice pack or cold therapy unit, because the ice can irritate your skin. For the first 4 days after surgery, you should have a sponge bath only. Do not take a shower or bathe. After day 4, you may remove your dressing and shower, but you should not soak in a tub, as this will increase the risk of post-operative infection. Redness and pain around your surgical site is common and normal. However, if after 4 days you have persistent drainage, or you think you may be developing an infection or a deep vein thrombosis, you should call your surgeon or visit your family doctor if you have concerns that something is just not right. At approximately 2 to 4 weeks after your surgery, you will have a scheduled follow-up with your surgeon, at which point your wounds will be checked and your questions will be answered. Intensive rehabilitation will be required to regain your strength, agility, balance after your surgery. You will be given a comprehensive rehabilitation program at the hospital, and it can be also found on our website. In the first 3 months, you will need to go to physiotherapy more often, and then in decreasing frequency until at least 6 months. We strongly recommend you discuss an appointment schedule with your therapist, particularly if you have limited or no insurance coverage. In this situation, you will have to do more of your rehabilitation at home, but we will still want you to have some physiotherapy visits spread out throughout the first year after surgery. To protect your new ACL, plyometrics, which are jumping and agility drills, should not be started any earlier than 3 months. Your physiotherapist will guide you through our protocol. Thank you for watching this video. We wish you all the best with your surgery and your recovery. If you have any questions or concerns, please feel free to ask your surgeon or any member of the surgical team. For more information, please check out our website. Thank you.